For decades, scientists have been staring at the exact genetic mutation that drives the vast majority of pancreatic cancers. They knew exactly what was causing it, but they were completely unable to stop it. It was literally like looking at a locked vault with no keyhole. Well, today on this explainer, we are diving into how a groundbreaking new drug called Daraxonrasib is finally kicking that door down. To make all this complex pharmacology easy to digest, we'll follow this roadmap. We'll start with the pancreatic cancer challenge, move into this historically undruggable target, break down the molecular glue mechanism, look at the data doubling survival times, highlight the real patient experience, and wrap up with the future of treatment.
All right, part 1. The pancreatic cancer challenge, a devastating reality.
So consider this for a second. Why does pancreatic ductal adenocarcinoma, or PDAC, carry such a dismal 5-year survival rate of just 6 to 10%? Why does it just shrug off standard chemotherapy? For most patients with metastatic disease, standard treatments really only buy a few brutal months. And part of the reason is that these tumors actually wrap themselves in this dense protective tissue called the stroma. It's basically a suit of armor that's incredibly hard for drugs to penetrate. But the real villain, that lies much deeper, right inside the cancer cell's genetic code. Over 90% of pancreatic cancers are driven by specific mutations in the KRAS gene. Now think of the KRAS protein as a cellular switch. Normally, it toggles between an active on state, telling the cell to grow, and an inactive off state. But in pancreatic cancer, these mutations act like a runaway train, stuck in the active on position. And you can see the breakdown here. The G12D mutation accounts for about 45% of cases, followed by G12V at 30% and G12R at 15%. That runaway train is exactly what fuels aggressive tumor growth and metastasis. Moving on to part 2, the undruggable KRAS target, an impossible lock. For literally years, scientists just labeled KRAS undruggable. It's essentially a smooth surface with no deep pockets for a drug to grip onto. First-generation inhibitors, like sotorasib, were a massive breakthrough, but they had a huge limitation. They only worked on the inactive off state of a very rare mutation called G12C, which makes up less than 2% of pancreatic cancer cases. Daraxonrasib, it completely flips the script. It is specifically engineered to target the active GTP-bound on state of the G12D, V, and R variants. The mutations that actually drive the vast majority of pancreatic cancers. Which brings us to part 3, Daraxonrasib, the molecular glue, the master key. So how does this actually work mechanically? Daraxonrasib, which is chemically known as RMC6236, doesn't just try to force its way onto that smooth KRAS protein. Instead, it acts as a molecular glue. It first binds to a highly abundant chaperone protein that's already in our cells called cyclophilin A, or CypA. Once it's bound, this new drug protein complex perfectly matches the shape of the active mutant KRAS protein. It docks right onto it, creating this 3-part physical blockade. This cuts off the downstream signals that tell the cancer to grow. And remarkably, it also acts as a gap mimetic, meaning it accelerates the cell's natural ability to break down the active tumor proteins, forcibly restoring the cell's off switch. Honestly, it is an absolutely ingenious biological hack. Let's look at part 4, doubling survival time, the triumphant data. The clinical data here really speaks for itself, and in the oncology world, these numbers are staggering. In previously treated patients, meaning folks whose cancer had already advanced despite standard care, Daraxonrasib practically doubled the median overall survival time. We are looking at 13.2 months of survival on the targeted drug compared to just 6.7 months on standard chemotherapy. To put that into perspective for you, getting median survival past the 1-year mark in second-line metastatic pancreatic cancer is a milestone researchers have literally been striving to achieve for an entire generation. And the victory here is really comprehensive. Progression-free survival, which is the time patients lived without the cancer growing, also doubled from 3.6 months to 7.2 months. Patients in the G12 mutation subgroup saw a 35% objective response rate, meaning their tumors were actively shrinking. But look at the tolerability numbers. Only 1.2% of patients had to stop taking Daraxonrasib due to side effects. Compare that to a massive 11.2% abandoning traditional chemotherapy. It's a real game changer.
Part 5, the patient experience, humanizing the numbers.
Dr. Eileen O'Reilly, who led the Phase 3 trial at Memorial Sloan Kettering, provided a quote that I think truly grounds the science. She stated, To date in my career, I have not seen this level of benefit from any single anti-cancer drug in this disease. Coming from a leading expert at a top cancer center, that really highlights just how unprecedented this survival benefit is for the entire oncology community.
And Helene Rubin's story perfectly exemplifies this breakthrough. Helene is an 83-year-old grandmother who actually joined the clinical trial after her pancreatic cancer had spread to her lungs. On standard chemotherapy, she was completely exhausted, constantly nauseous, losing weight. It was rough. But after switching to Daraxonrasib and getting her dosage dialed in, her lung nodules actually shrank. Slowly, she realized she had gotten her quality of life back. She's eating better, feeling less fatigued, and most importantly, getting back to living her life, not just surviving as a cancer patient. Now, to be absolutely clear, the drug is not without its challenges. It's a powerful systemic therapy. The most common side effects are skin rashes, stomatitis, which is an inflammation of the mouth and lips, diarrhea, and nausea. About a third of patients do experience grade 3 or higher adverse events. But the crucial takeaways here is that these side effects are generally manageable with proactive care, like topical steroid creams from a dermatologist, and they rarely force patients to stop treatment entirely. Crucially, in the safety population studies, there were absolutely no grade 5 or fatal treatment-related events. It's a pretty stark contrast to the systemic devastation we often see with traditional chemo. And finally, part 6, the future of treatment beyond monotherapy. So, where do we go from here? Well, the future is all about combination and escalation, and researchers are moving aggressively. The ongoing GI-102 trial is already showing a remarkable 58% response rate when Daraxonrasib is paired with frontline chemotherapy in previously untreated patients. Beyond that, scientists are exploring combinations with immunotherapies to recruit the body's own immune system into the fight. They're also developing novel PROTAC degraders. These are drugs that don't just block the KRAS protein, but actually tag it for cellular garbage disposal so it's destroyed completely. And they're even engineering nanoparticles to help these drugs punch right through that dense fibrotic stroma that shields pancreatic tumors. We've seen how Daraxonrasib has taken a target deemed literally impossible for decades and elegantly dismantled it. It practically doubles survival time, shrinks tumors, and most importantly, gives patients their lives back. So I want to leave you with this powerful thought. As precision technologies like molecular glues turn the historically undruggable into the highly treatable, are we finally witnessing the beginning of the end for terminal cancer diagnoses? If we can drug KRAS, what impossible lock will science pick next? Thanks for joining me on this explainer. I really hope you found this deep dive as fascinating and hopeful as I did.